for this warm welcome to everyone for this session. And thank you, Sangeet, and big thank you to Pallium too. So going on to our session as such, today's topic is ethical issues. Like mainly you're going to see end-of-life care and medical ethics. See, both these are intertwined. So before we go ahead, I just thought of just giving an overview. In palliative care as such, like you've all had so many sessions on various aspects of palliative care. So palliative care, the definition, what all are the components of it. And then when you come to another important topic is end-of-life care, there are always some queries in everyone's mind, whether is this the right way to do it, how to do it, and am I doing the right thing? So these type of things are there for the physician and from the family point of view also. So to have some clarification on all those things, the medical ethics is going to help us to make the wise and correct medical decision. Okay, so with that in mind, we will move forward today with some initial aspects of what is or how, what are the different aspects of end-of-life care. And then we will go in depth with medical ethics and their clarification with some case discussions. Okay. What are our learning objectives? As I said, this is what is the small introduction that we'll see various what are the transitions in an illness trajectory of any life-limiting illness, and explain the principles of biomedical ethics and application in end-of-life care, exactly what I was mentioning, and also find out, is there any legal protection and provisions available already which can be used, and knowing them will be of immense importance to all of us when you're actually practicing it. And then some terms, what are there, why are they there, what do they explain? Next slide, please. Next comes transition in any illness. See, all of you would have known what is the definition of palliative care, no? It is an approach of managing a patient who has like any life-limiting, life-threatening, or any serious health-relating issue. All these will come into palliative care. So, palliative care as such is a very wide term, and it can last also. See, and also you would have seen a graph which many people would have shown you. When do you start palliative care? You start from diagnosis, and it goes a long way. It goes hand in hand with curative care. And then you have various phases. Then you have something called as end of life care, terminal care, actual phase of dying, and we go also into bereavement. So exactly what you would have seen in the initial lectures of what is palliative care is what is given here. So you see that transition. See, and in that transition, what are you going to see? See, you can see some dips. If you see this graph, what is showing, there can be some dips, and each dip is one event. It could be some infection, some recurrence. You can put anything, and all what I'm telling is not Greek and Latin to any of you, because you are seeing any patient. This we are explaining into any illness. So this is what all of us see all through our life. So at the time of, for example, when diagnosis, suddenly they would have been unwell. So that is why they're coming for the diagnosis itself. So that itself, you could take it as a dip. And then as the disease processes, so if you see this, what is given there, like you have give time, in due course of time, what happens from diagnosis. Okay. So diagnosis, then they're getting some curative or controlling the symptoms and controlling the disease type of management. Okay, so in that phase, the dip or the incident varies from person to person. And if you also see one thing, gradually there is a decline. So you're seeing time here. If you put a vertical axis, that will, you can put it as performance, which we will see in detail in the next few slides. So as is given here, you have early diagnosis, disease containment, then decompensation. Then the disease progresses where it is not responding to the curative management. So that is where the compensation element is not there. So decompensation happens. And that is where, from the patient perspective, if you see, they become more dependent. They are unable to do their own daily ADLs or activities of daily living. And then it goes on further to a stage where they are unable to do anything for themselves. They may become bedbound and get into the final stage. Okay, so this is a rough transition for any illness. Next slide, please. Next is this slide is quite important, and I will go in bit detail, and it's one of the things which everyone, if they can understand, that will make management and things helpful to a very great extent. See, these are the proposed trajectories which are mentioned for all the patients with various diseases and illnesses. So if you see the first one, where it's mentioned as sudden death, again here you have a vertical axis which has function, and a horizontal axis which is denoting time. So if you see on the vertical one, you see something mentioned as function. So anyone who doesn't have any other medical issues, he or she is fit and well, able to do all their activities, no comorbidities, that type of person may have a very high performance status. So what happens for some like that, they may have something called as sudden death. See, these are the proposed trajectories of dying. What are the various ways that a patient could die? Okay, this first one, sudden death, is examples are accident or any sudden cardiovascular, massive cardiac arrest. So those type of patients will have a very high performance. They'll do everything as they would do. And suddenly one episode or one event, as we saw so many dips in previous graph, here one dip is enough to bring death. So this is called as, this is one type. Roughly 7 to 10% of the population only will have this type of end. Then the next one is, you see, terminal illness. In this one, what happens? The function is still the same as the first one. But suddenly, this is called as waterfall effect. See, suddenly they were doing everything well. One diagnosis of this, normally, this group fits into malignancy or cancer. So what happens? That diagnosis brings their performance suddenly from such a high level to the lowest level. And then the time variation here varies from person to person and to the diagnosis of the disease, progression of the disease, when the actual diagnosis is made, and the nature of the disease. So this one, roughly 15%, 15 to 20% may fit into this category. Then the third category, again, this third category is again very common and one of the important things for all of us to know, because all non-communicable diseases, any organ failure, it is mentioned as organ failure, any organ failure, end-stage liver disease, end-stage heart disease, end-stage kidney disease, all can fit into this. So if you see this graph, please see this one very carefully. See, to start off itself, the function is not as it was in the previous two. Why? Because the disease per se itself brings down the performance. One of the organ is affected. One or many organs may be affected. For example, you take diabetes, it has a very important impact or a back pressure effect on many organs. So, like that, when multiple organs or one organ is affected, it is not 100%. So the function is already brought down. And each episode, like for example, infection, or they can have a sudden diabetic ketoacidosis. We'll take diabetes because that is very, very common. You can take like this examples for anything. You can take COPD. They can just have a infection or a acute exacerbation of their disease itself. So these type of thing, each dip is one event. So after each event, they do recover. In today's world, you have so many intensive care management options, everything is there. So they do recover. But if you see after each recovery, they are not the same as they started. For example, you see the first dip and then see the third dip. After the third dip, they have recovered. But if you extrapolate that to the vertical axis, see where their function already comes to where they started. So this is something to be understood by the medical profession and slowly conveyed to the family too, and to the patient also. See, these can be done by physicians who are seeing the patient regularly in a methodical, sensible, clear way, not in one go. Like, see, then here communication plays a very big role. You all would have had sessions on communicate. How you communicate, what you communicate. There are some certain C's of best communication. Whatever you communicate should be clear, concise, complete, coherent, and courteous. Everything, all these you have to follow and then convey it to them. So that is again our duty. So once that is conveyed, then further management, nothing will be difficult. So this again, any type of organ failure will come into again, this category also will be about 15 to 20% probably in the population. And then the last one, frailty. Any like nowadays, we like according to global statistics, aging population is what is going to be increasing by 2030, 2050 and all. The whole world expects that the whole demographics itself might change. The old number of people who are old may increase, and internationally we are seeing this now. We see a lot of 90, 100-year-old. We see patients, and it's not only me, all of you are seeing. So all of you will be knowing. Roughly in 2-3 months, if you see, you will be seeing few 90 and 100-year-olds. Okay, so that what happens is, see, their function status is starting itself is more closer to the lower side, and it's a very, very gradual decline, and dementia, neurological issues, all those patients will come in them, and it is a very, very long drawn process. So this has to be, this one again, this could be 40 to 50% of the population can be in the, see, roughly if you see all these four in total will form that 100%. So that is one idea to be had in mind. So first one 10, second one 15, second and third could be 15 to 20%, and then the rest will be the frailty. So anyone has any doubt in this, please do ask me here. I don't mind explaining this once again, because this is one of the important things to be understood well. Sangeet, anything on the chat or something, please see, and if anyone has a doubt, they can unmute and ask also, please.
Okay, ma'am. Nothing yet, ma'am. Just good afternoon.
Okay. So in that case, then we'll move on to the next slide, please. Okay, then we will go on to what are the main cardinal principles of medical ethics. So these are the 4 important pillars: autonomy, beneficence, non-malfeasance, justice. The verbal meaning for them: autonomy is freedom or independence. Beneficence, do good. Non-malfeasance, do no harm. Justice is wise, sensible utilization of resources. Okay, these are the 4 words, and 4, what do they mean? And okay, to follow all this, how you have to do all this? You have to do all this with few important elements or aspects. In that, truth telling, giving respect for life and respect for the person. Inside each patient, there is a person also. That also to be had in mind. Just a click on this slide again, Sangeet. The main thing how to be done, it has to be done with dignity. Sangeet, if you click on this slide once again, it has to be done with dignity, honesty, and clinical integrity. See, again, the whole session, I'll keep telling everything is important. Yes, all of you also will know, because every word counts. And if you do everything as said, you will not have any issue. But doing that is not an easy task. Okay, next slide. So we'll, as I said, see these things. No, if I say independence, oh, what is this? If you do it with a case, it will make more sense and more. It'll become more clear. So for that, what we're going to do is we'll go ahead with the cases which will be coming up from now onwards. First example is the 78-year-old woman who has stroke, hypertension, and type 2 diabetes. Okay, here again, listen carefully to every element mentioned in each case. She is cachectic, bedbound, dependent on all activities of daily living. Cachectic means she's skin and bone. And next is she's brought to the hospital with reduced urine output and reduced oral intake. And that time admission, she's been diagnosed with urinary tract infection, and already she has end-stage renal disease. And she's advised for antibiotics and dialysis. Then comes the important part. At this point, patient says or patient refuses, while the sons want her to undergo dialysis. So this is the case. Okay, is everyone clear with all what is said? Or if you have any doubt with the case as such, please ask now itself. Okay, if there's no doubt, then how many of you can we just come out of this presentation so that I'll see everyone and then we'll go back, Sunny. How many of you will be telling that I will go with the patient, and how many will say, no, I will go with the son only? Just you can unmute and say, because this is how, because when you see patient, you have to make the decision, isn't it? So that time, can you say, no, I will look at the book and come back? No. So please don't hesitate. Whatever is your opinion, just say and then we can move. How many of you will say that I will go with the patients? Patient says, I don't want. How many would you say yes and why? And like both ways, is there anyone who says who wants to go with the son and why? See, only if you all interact, it is going to be helpful for you. So it is your opportunity and chance.
Kriti says with patient, ma'am.
She goes with the patient. Okay. Anybody else differs?
Please put your answers in the chat box.
I've opened the chat box also. Once I'm in this screen, I can open the chat box again.
Okay.
So Kriti, why? Can you just say why? Like you can type or speak whatever is convenient to you. Why is that, Kirti, that you want to go with the patient? And do you work in palliative care already, Kirti? No. Okay, no worries. And in that case, why do you want to go with the patient? Okay, then we'll go back to the slides. Okay, see here, important things is that, like we saw 4 important pillars. So in that, each one we have to keep in mind. So the patient refuses. See, patient in second line, what did it say? She's cachectic, bedbound, and dependent on all activities of daily life. See, it is the patient who is going through the final phase, that she is the one who is for every act, like to stand, sit, to move her legs, everything. If someone is dependent on somebody else, how will each one feel? How will that person feel? This is where empathy comes in. Put yourself in that patient's shoes, we say. So in that situation, how will the patient feel? And see, there the patient has the utmost right. So that is what is autonomy. So here, even though the family, see, we are not disagreeing or disregarding the family. Okay, so that is why I said when I was explaining the trajectories of dying, if in the third type, when you have organ failure, you explain to the patient and family what the condition. You see, when you see that graph, it is constantly going down. Is it coming down and going up to the at least to where they were? No. If you explain this to the patient and family, these type of situations will not come up at all. Why the family is trying to do it, is doing it with utmost love, care, and affection. Okay, so from that point of view, the explanation by the physician to the patient and family is very important. So, and you have to see all, it is not a blind, instantaneous decision taken. You see each factor. She's already bedbound. So, all that shows her nature of the disease, her state. So, and before this trajectories of dying, I showed another graph which showed gradually as disease. That is the pattern of the disease, and that is how the progression is going. These are all medical information, and this is all what all of you have read all through medicine, and we all keep on reading, updating what happens, how it goes on. And then you've got one important thing here, end stage renal disease. And this time, how, with what has she been brought into the hospital? With reduced urine output and with reduced oral intake. So all those show you how the disease has progressed and how the patient has been in the last few days, months, or something like that. So these are all indicators of what her state is. And with these, there are clear-cut scales and indexes which you can plot and know their prognostication, or how they will move forward from where they are. Age, disease. You reduce urine output means urea creatinine may vary. There are very important factors: urea creatinine, urine albumin condition. So these are all, like, there are standard index and protocols which will give you numbers to say what is their current condition, what will be their prognosis, what will be their mortality. With these factors, how long a patient will live, what is the percentage that they can die in 6 months, what is the percentage that they can die in 1 year. All those can be found with clear cut. They are fact, like there are factors, for example, something called as Walter index. So you put all these patient figures into that, it will give you information of their prognosis. So like that, all that is clear here. You explain all that and then explain both to the patient and the family. And then collectively the decision is made. Okay, so there is no difference of opinion anywhere. So because many people ask, oh, they don't know, I don't know. Yes, everybody, all don't knows have to be corrected by getting to the knowing state. Okay, next slide, please. So what I explained only, will you advise the patient? What will you do? And all what has to be, what I've explained here is what, see, you should respect patient's wishes. And if there is any benefit in sending her to a higher center, we will definitely send. But at this stage, end-stage renal disease, no, you will not put. Will she benefit from going to another center? No. When the decision is no, no point sending her to a higher center. So all these are wise, clear-cut medical decision made, not having doubtful or not knowing. That is not the way it has to be done. Next slide. So then in these situations, as I said, it is not one person. You explain everything, collective medical decision, putting all these factors. Okay. And then the first one, or how or who makes the decision. And then next, second box is important. Here, the patient herself said. So in that condition, what you have to check is whether the patient is awake, alert, comprehensible. That means what? Patient is able to understand what the situation is, explain, and she knows the risk also. So for example, it is our duty to explain to the patient that if you say no to this, you may die. So that is the natural process because your disease is progressing. So all those explanations are given to the patient and then the decision is made. So see, you have to check whether the patient is able to understand. And more so what you can do, you can explain and ask the patient to repeat in their own simple words when they have understood. Okay, so that is the important thing. And here communication comes and plays a very big role. All of you would have had enough sessions on breaking bad news and how to tell, how much to tell, what to tell, make sure whether they're understanding, ask them to reply, all these. So once you know that the patient has understood everything and then still she says no, yes, we will have to stick to the patient's wish because she has the right to make the decision because she also has the capacity to make the decision. Okay, next slide. What happens? So here, see, the respect, everything will be there only how you have had the communication. And especially in India, important collective autonomy is the norm in Indian culture because here West and East have different opinions. You have to follow what is the norm. See, always patient has the upper hand. Okay, so patient's decision is final, but collective autonomy means what? The family also has to be explained as the patient has understood, and that is patient's wish, and this is the disease trajectory. And so even though you would prefer, but the benefit or outcome will not be good because of the current medical condition. You explain all that to the family also. So then the family or son will also agree with the mother's decision. So that is what is called as collective autonomy. Okay, and we have to inform everything and then a combined decision is made. Next slide. Next slide, please. So here the conversations have to be in a nice way, as I said, courteous way. I am telling you have to follow those type of things. So all these are communication clues which you would have known before. Next slide. Due respect for each other. So patient autonomy is to be upheld at all costs. So we have to explain everything in detail and then give respect for the patient. Next slide. So then next, here, so far I said patient is able to make. If the patient cannot make the decision, what happens next? So for example, patient has dementia. Go ahead, next slide. So then it will come. See, always anything that is best for the patient only will be done. But just because patient cannot make the decision, you will see who is next of kin. That is, if it is husband, wife means, so spouse, children, or they may be, sometimes there's nobody, then they might have nominated someone. Or if no one is there, some legal document may be there. Even then, nothing is there. Always everything is done in the best interest of the patient, in the best interest of the patient for the patient. So that is the final thing. So in some situations, as I was telling, if there is some legal documentation, you follow what is there in the legal document. We see about that when we see legal documents at the end of the session. Next slide, please. So these things, no, that's what. Next, we will move from one ethic to the other gradually. So see here, no, always we saw autonomy as first and beneficence as the second one. See here, when the patient is having dementia or unable to make decision, what we see what is in best interest of patient. That is doing good. So if someone is having severe dementia, not been able to do anything for 2-3 years, last 2 months she's not moved out of the bed, already having bed sores. So you see everything. So you do something in the best interest of the patient. So we will do what is best for her. Do complete supportive care. Okay, explain this to the family and then let time or nature take its course. Okay, providing supportive care or end of life care in the best possible way for the patient is beneficence on doing good. Next slide, please. So these all, these main things, what are the problems means, you have to, the professionals also have to understand what is the correct thing. So from that point of view, knowledge for professionals, awareness for the family, explaining what are the outcomes, all these have to be done. Then there will not be any difference of opinion, and it is all done in the, like, doing good. These will all come under beneficence or doing good for the patient. Next slide. Next is another case. So far, any doubt? We'll go back to the paper. Any doubts or any queries in the chat box, Sangeet?
No, ma'am, not.
Okay. So next case is a 20-year-old boy with metastatic osteosarcoma of the lower end of femur, who also has lung metastasis and anemia. He has a large tumor on his thigh and insists on getting operated. Both parents and the patient are adamant that they want the operation done. So here, what should the surgeon do? I'll repeat, it's a 20-year-old boy with metastatic osteosarcoma of the lower end of femur with lung metastasis and anemia. And the parent and the patient want surgery. So think of all the elements given about the case and what should the surgeon do? Can we come out and see if anybody wants to explain or say anything? Anyone? Just little bit of information, Sangeet. All of them are from different parts of treat anemia first. Someone is telling, yes, very good. Like just how many of you are working in palliative care? Is there anyone already working in palliative care? If so, please like type on the chat. Can I take that no one is working in palliative care at present? And where from are they all, Sangeet? This group of nurses, are they all from
Mainly
any one particular area?
Haryana, ma'am. NHF from
all
there.
are from Haryana. Okay. Okay then. Okay, then in that case, let's go back to the slide. Okay. Come to full screen. Yes. Surgeon should explain about the surgery. Surgeon should explain about the surgery, whether they should perform surgery or not, what are the benefits that the decision. Very good. Kirti, really exactly what has to be done here. Where do you work, dear? You can unmute and speak, Kirti.
Yes, ma'am.
Where do you work?
Ma'am, at SDH Ratia.
Hmm?
SDH Ratia, Subdivisional Civil Hospital, Ratia.
Uh-huh.
Fatehbad, near Fatehbad.
Okay. So how many years of experience you have?
Actually, I only have 1 year experience. It was my new joining in July 2022.
Very good. See, exactly. Well said. The main job of the surgeon is to explain, okay, and tell the risk and benefit. So here, the main important factors are, it is a metastatic CA already. Yes, it is a very young boy. I am not denying. Okay. And already there is lung metastasis and there is anemia. And here it says large tumor. Okay. So someone had messaged you have to correct anemia. Yes, we have to correct anemia. Fine. Okay. But overall, if you see, yes, anemia correction has to be done. But if the tumor is very big and already it has said here, little bit more information we may need about this case, like how long the disease has been, is the disease actively progressing, staging of the disease. It says lung metastasis, but if we get more information about the disease, if it has metastasized to the lung, as it metastasized to others, many more places also, and how severe is the anemia? Okay, and if the tumor is so big, so here you have to do something called as risk-benefit ratio or harm and benefit ratio. What are the harm? What are the benefits? See both, explain both to the family, and then make a decision. Okay, go to the next slide, please. So here, see, what are the benefit? What are the harm? So benefits are, yes, taking the tumor off will give some benefit for the patient. And any tumor or mass or thing, it will cause physical disfiguring. Okay, that is also very important. Like head and neck tumors, now patients have they lose their identity. Everything is everything easy said than done. So only when someone goes through all these things they will know. So for this 20-year-old, this big tumor may be affecting his mobility, then he can't do anything. Even wear dress and things he may not be able to. So there are so many factors. So physical appearance, psychological impact on it, everything is there. So from that point of view, he may get. But see the harm. The anemia, his hemoglobin may be 3 or 4. Okay, how much ever you give and then you remove. If you're going to debulk such a big, it could be a big vascular one. We don't know whether there is invasion of any vessel or anything like that. So that's why I said more in detail. And then anesthesia point, there is lung metastasis. He may need general anesthesia, and will he cope with the anesthesia? Then the pain may be intense. Okay, pain could be managed. Okay, with very strong painkillers, keeping him in intensive care, something you can do. But is the harm more than the benefit? So if you see this, why they put this balance? So the harm is more than the benefit. Click again, Sangeet. Keep going, whatever is there in this. Fine, leave it there. So these all should be explained to the family, patient, everything, and then if you explain everything, no conflict. Okay. So next slide. So the next, like what third one is non-malfeasance. What does non-malfeasance means? Do no harm. Okay, beneficence is do good. This is do no harm. So here, yes, the patient and family want surgery. But if you tell them that by having the surgery, we may lose the patient. I said we may, because the risk is more than the benefit. So at that time, what will happen? They themselves may turn around and say, no, we don't want that. We were not aware of that, so we wanted surgery. You did not tell me that could happen. So it is the duty of the physician, surgeon, anyone to explain. Then from this we move on to another thing. Click again. Turn. So here, even though you may think, oh, the patient wants, you only told me first thing is autonomy, patient's right only you have to follow. Now you're not following. See, it's not just, we all have something called as wisdom, intelligence. So that is why you have to use. You just, you even on a day-to-day living, you do something what is the best and what is right. No? So here, non-malfeasance overrides autonomy. So as I said, yes, the patient's right is there, but it is also the doctor's right to explain the risk or harm. Then, as I said, the patient himself may turn back and say, no, I don't want surgery. So this, we are still giving respect to him. But at the same time, we are also maintaining or the physician's job of not doing harm. So that is why, as I said, no, all these ethics have to be understood clearly. Many times people, all these doubts, even though none of you want to speak, all these doubts will be in your mind, heart, whatever you say. Okay, this will be there. So going through all this, many of you, these will be helpful not only for today. When you see cases, this is what will help you. Okay, so always you have to weigh the risk benefit, explain, and then make a decision. Okay, that is the next slide, please. So next in this, when you read about end of life care and things like that, you'll be seeing something called as doctrine of double effect. What does that mean? Okay, for that we'll go through this example, which will make things clear. Okay, whenever what we're going to see is 25-year-old married 6 months ago only, suddenly comes in with severe pain abdomen, and she's in a state that she comes into the hospital emergency, and then immediately within few minutes she even gets to a stage of collapsing. They find out pregnancy test done positive, and then probably it is ectopic pregnancy. She's having a very tense abdomen. She's in that state. Okay, so what happens there at that point? Salpingectomy is done, and to save the 25-year-old. Okay, a single act having two possible foreseen effects, one good, one harmful, is not always morally prohibited if the harmful effect is not intended. Here, we had to save her life. She was 25-year-old, married only 6 months ago, all that I said. So by this surgery, she lost one salpingectomy or salpingo-oophorectomy. Something had to be done. Okay. There, saving her life, even though she loses one tube, her life is saved. She can very well become pregnant, have children with the other tube. Okay. So here you should not think that, see, this where one, as it read here, one harmful act of removal is done is to save her. This was not intentionally done. Someone doesn't go normal tube, removing the normal tube is an intentional bad effect. So there are many such incidences which can happen. One such example is this. Another common thing is when they give midazolam in end of life care, that also people may ask, oh, midazolam will cause central nervous system depression. So you are in. No, here, that is the thing. Pain relief and allaying anxiety is the important thing there. So that has to be kept in. So the action must be morally good. You must not intentionally desire for any bad or negative effect. So the good effect must be as immediate as the negative effect. Here, saving her would have been possible only if self-injectomy was done. If that was not done, that 25-year-old who collapsed will die. Okay, so the good effect and the bad effect, if you see, good effect should be intentionally important there. That is why it is done. And the bad effect is also not an intentional bad effect. It is a coincidental bad effect, but it has the good overtakes the bad and it is not intentional. These are the two important things to be understood whenever you see something about doctrine of double effect. Next slide. Third case. Okay. So far, so good. Anyone has any doubts? Please do type or unmute and ask. Otherwise, we will move forward. No, ma'am. Very good. Thank you. At least one person is responding. And none of you should have any fear, no? I am only a normal human being. I'm going to joke just now because none of us will do any harm. Don't have any prejudice that, oh, if I ask them. And I feel free. This is a platform where all of you can ask and clear your questions or doubts, because if you have a doubt when you see a patient, so many of us will not be there, and I may not be there to help you to say make this decision. So any doubt, please do ask. If we can help you, I'll be willing to help and clarify whatever is possible. Okay, give up your fear and things, no, which will not help in any way. And especially when you're studying, you should never have any such apprehension or hesitation. Okay. The next case is a 57-year-old man with advanced metastatic cancer of lung who is severely breathless due to his progressive disease. In all these cases, no, every word is important. And see, the third one, all reversible cause of dyspnea have been ruled out. So whatever possible treatment could be done, all those options have been tried. But unfortunately, he's not responding. Now he's coming to a state where he's coming into hospital and he may need artificial ventilation. What is your take? What should be done here? Here, I'm going to add on little bit more information, or how can I say, little bit more clarity. You have two patients coming. Okay, one is this patient, another is a 27-year-old, generally very busy, active manager in some company. He was doing everything till yesterday. Suddenly he's been unwell 2 days with fever. He collapses in his work and he's found to have severe pneumonia. He doesn't have any other medical issues. No diabetes, no hypertension, nothing. He is fit and well. He is a very active person. So both those patients are brought into the hospital. There is only one ICU bed available. Okay. Now I'm trying to make the decision making easy for all of you. So you have this 57-year-old with all this metastatic cancer, progressive disease, all reversible causes tried, nothing is working. He has come into the hospital, and this 27-year-old also is there. There's only one ICU bed. What is the correct decision? Who should be ventilated?
Twenty-seven-year-old.
Yes, 2, 3 are. You are very good. 27-year-old. Can anyone say why?
Means that boy is suffering from severe pneumonia on a young age.
May I
And
know who is
that
speaking?
fellow, ma'am,
Who is speaking?
I'm Sanjukta Bak, speaking from Sapa, ma'am.
Sunita.
Sapa. Sanjukta.
Sanjukta. Okay.
Yes, ma'am.
Hmm.
From Champa Hospital.
Okay. Go ahead. You said he is having pneumonia, and then?
And that 57 years old, suffering from cancer to long time. And suffering from long time, ma'am. And they
Very good. See, this is how analysis. See, it's suffering from long time. They've already ruled out whatever can be done. And then the second line said he is having progressive disease. So if it is progressive disease, it's getting bad to worse. So it is not in a phase, it is going to get better. And all they've tried. So if you see like that, where the outcome, where there is a possibility of better outcome. Okay. In that way, the resources, justice means utilizing the resources properly. Because again, any resource belongs to everyone in the world. So there is no rule that only one person gets and the other person doesn't get. So that also has to be kept in mind. So that you have one intensive care bed, and if it's a government hospital. Okay. And then that bed has to be used properly. Okay. Anyone's resource has to be used wisely only. It is not only one individual's resource. Okay. And those situations also you have to see in any these type of conditions. You also have to see if you have to put the, like I said, general resource. You also have to put in mind the family's resources also. No one has got the right to put the family to a state of debt. When you know that nothing can be done, you keep on making the family spend the money and lose the money. And then the surviving family has to survive. This also has to be had in everyone's mind. Okay. As we say, wise use of resources. The resource has to be used only in the right way. It should not be misused. Okay, so that also is important. See, these are all, like as we say, no, this is what is ethics. I said no, very strong words we did use. Dignity, respect, truth. See, all that may sound, yes, they all carry enough weightage and they have to be respected. So here it is a clear medical decision. Okay, here no personal thing is coming here. Many people, all these queries and doubts, no, have to go away. It is only a medical decision which is being made. Okay, next slide, please. That's what. Okay, here. Now go to the. So all these we have done. Leave it here. So now see what here is where comes health. I was telling healthcare is a scarce resource. Yes. And everyone, all these what I've said only have been given here in points. Are we allocating that precious resource to the ICU justly? Are we can see all what I said only is just 4 points here. Okay. And ethics, what is ethics? Ethics is knowing the difference between what you have a right to do and what is right to do. Okay. So just power, hierarchy, that alone doesn't, unfortunately, the world is not as I speak. Okay. But that doesn't mean that you also have to keep your mouth quiet and carry on. Okay. So we have to explain, express, and try our level best to do what is the right thing. Okay. So just because I shouldn't do rubbish. Okay, why am I asking you all so many times? Please ask. See, it is my duty here as someone trying to explain to you, my duty to make sure that all of you understand. Today, my role is to make sure you all understand. Yes, my professional role is also there. But today's role is, so that's why I'm asking again and again. If I don't do that, then I don't do justice to this 1.5 hours. Okay, next slide. So then again, more in detail. See, these are statistical figures. End of life care consumes, these are all international, 10 to 12% of any healthcare. You see, for anyone, like for example, someone, we take the type 2, like the second trajectory, waterfall effect. Someone was there till their age of 70, they were fine. They didn't need any expenditure. Fortunately, many are like that. See, one thing I would like to tell, don't think always everyone goes through, we are like billions and billions of people in the universe. Okay. We see, yes, difficulty, hardship, all is there. But many people have a nice life and then they might have been healthy also. Suddenly, last 6 months, someone was not well. But in that 6 months, they might have spent so much of money on health care rather than they might not have even spent all their 70 years. So that's what they say, because it is expensive. No, if it was cancer, any treatment is expensive, any medicine is expensive. So like that, that's why I think that 10 to 12% means that's the truth. Okay. And then it is physician's duty to an individual patient and to society as a whole, in cases which limited resources, that is, they're used properly. And then what that patient needs, that has to be used. What just not to be consumed by the intensive care facility and utilization. And when something is futility, means when nothing can be done, no point wasting. Okay, so all these have to be mentioned and explained. Next slide. That same, what I said, no, just because intensive care is there, say drying is prohibited, that it's not possible. That is the natural process in life. So is there to some extent somewhere, many are hesitant or scared to say the word death and dying. But is there anyone in the world who can live forever? So it has to be explained and accepted and said nicely and taken care of. Not that if you say that we look after the person until they die, the family will also be very happy to, and all these, what I'm telling you all know. See, that is what palliative care is. It's not, we are not telling, oh, cure is not possible, so we are not going to give care. We will give. Cure may not be possible always, but care can be provided always. Okay, so these things, if you explain to them, tell them that we are there to help them, then it will not be an issue at all. Next slide. So then here from now on, we'll go into some important terms. What is withholding or withdrawing? So as we were telling, when some patient is having a disease, for example, the last case, 57-year-old whom we saw, is in a state where they've tried all options, tried all measures. So nothing beneficial could be done to him. Okay. So at that point of time, just keeping him or relieving all his symptoms and not going ahead and putting him on the ventilator. So that is one stage where is called as withholding or withdrawing. Both the word mean the same. Okay. Where you're not giving the treatment, but you are not giving the treatment for cure, you're giving the treatment for care. Okay, that is the, and you should never confuse this with euthanasia. Okay, next slide. Euthanasia is an active, deliberate act. So that is different. Okay. And it is illegal in India. And as I already said, you never confuse this with that. So euthanasia is not practiced in India, and it is not a legal thing. And that is an intentional act. So you don't do that, and it is not medically allowed. So, and as I said, withdrawing and withholding life support is not euthanasia. Please don't confuse. Next slide. And another important thing is about advance directive. From here, just few things only we will be going on to. What is advance directive? In January 2023, there was a legal law passed in India which allows any adult to make a decision on their options of management when they are not well at their final stage. If they can make this decision ahead. Okay, for example, 60, anytime they can make this decision, because we don't know when dementia or something may come to us. Okay, at that time, we may not be able to make the decision. So our we say compos mentis, that is someone can comprehend, who can understand what this is. You can understand what is life, what will happen if some disease comes. Whereas when someone is having this dementia, they are not in a state to make the decision. So someone can write and keep all details of what they want when they are unwell. So that's what is given here. The right to die with dignity is a fundamental right, and any adult human being having mental capacity to make an informed decision has right to refuse medical treatment, including withdrawal from life-saving devices. Don't put me on ventilator and all. You can write it. Even little important things. I don't want tube feeding. I don't want this to be done. I just want to follow what nature takes. So like that, these information can be written and kept and just be signed by a notary or a notarized person. Before, it had to be signed by a magistrate, but from January 2023, it has been made easy that these type of documents can be made and kept. So an adult human being of conscious mind is fully entitled to refuse medical treatment or to decide not to take medical treatment, and may decide to embrace death in natural. Exactly what I said. Okay. So in clear words, you can write and keep, and it is a simple document which can be made, and full information about this is there on the Pallium website. Next slide. And this is what is called as Advanced Medical Directive or Living Will. Okay, and all what is explained is there, and this has been officially approved. Next slide. So living will, what all it is. It's it helps to guide the medical profession and the family. And another important thing what I would like to say is, whoever makes these type of document has to personally explain to the family. Because what will happen if someone makes this decision and they have not conveyed it to the family, even at that point of time, they may come and fight. Okay. So it is the duty of the person to write and explain to the family and give it to the doctor who is looking after them. Okay, so that everything is clear and no confusion happens when they are suddenly not. Next slide. So for these things, there is enough, there is a big body of doctors, lawyers, well-wishers in India, and who make this end-of-life care policy. And there are many such documents. There are guidelines, and there are documents there. If anyone is interested, plenty of information is there in Pallium, Blue Maple document. All these documents are there. And nowadays, more so, they are creating certain senior people in each important cities and things, who will be board. 2 to 3 doctors will be there in each board, in such board, who will guide the rest of the medical professional in each city and things, so that these decisions can be made both private hospital, government hospital. There'll be a unique board which will be there, which will help to have these documents and decisions made smoothly, so which will help the patient and the organizations also. Next slide. I think a little bit about, see all these, main thing is that dignity for patients and profession. The main thing is truth telling. You have to tell the truth with honesty. And then next, you have to give no false hope. You have to give realistic hope. What is the truth if you explain? And then tell them what is realistic hope is telling them that yes, cure is not possible, but care can be possible till the end of life. We can give a dignified death. We can give you assistance on managing all symptoms, how end of life care will be, how can be done. For example, in this, you're giving information and communicating what, and also document all what you're telling to the patient and family then and there. And one more query which will normally come is, normally at end of life care, everyone will ask, oh, we can't, even in our first patient brought in with reduced urine output and reduced oral intake, they will ask, oh, we want to feed the patient, okay, because that is love and affection again. So in that situation also, you have to weigh the risk benefit. Explain to them what are the benefit of putting a tube, what are the harm of putting a tube, how is food going to be helpful. See, for example, in the first patient, you saw already reduced urine output, reduced intake. Then decompensation. When we saw in the first trajectory thing, we saw something called as decompensation. That is, body is shutting down. So their body is shutting down means it is refusing to take intake because it is not able to work. So in those situations, by giving feed, is that going to correct the decompensation and bring them out? So it is our duty to explain here. So in these situations, you have to tell them what is, for example, if it is Riles tube, what are the Riles tube doesn't give assurance that they will not have aspiration. Okay. And then if they want intravenous fluid, that can cause pulmonary edema. When already body is shutting down, heart failure, lung failure, you give more fluid, they may cause pulmonary edema, and that can cause death. So it is our duty to explain all these. So these type of explanations have to be given, and then you can give suggestions. We can give sips of water, or last option, we can give some subcutaneous infusion. You would have heard about subcutaneous infusion in one of your sessions. So it is our duty to explain and tell, and then give them time to make the decision, and then do something which is again in the best interest of the patient. Okay, next slide. So that's all these have to be kept in mind. I think that is with main few things. DNAR means do not attempt resuscitation. So that and all has to be decisions made by the patient or doctor team. And then those are things which will be there in the medical records or documentation, which will help the physician, family, and the medical team to make decisions if such episodes or incidences happen. I think that's it. You can come out of. Is there any case presentation, Sangeet?
No, ma'am, no.
Okay. Okay. Anyone has any doubts, please do ask. Is it all clear? To when you all came for this session, whatever doubts and things you had, has it clarified?
Ma'am,
Please go ahead.
ma'am, just we are
Can you mute that person, Sangeet? Or you want to ask? Salim Ali? Okay, then Preeti, please go ahead now. Preeti was the person who started talking, isn't it?
Yes, ma'am.
ma'am.
Yes, go ahead.
We are now serving the patient that many cases.
Hmm.
And we are not starting now treatment. Where every day we are going to village area of survey on find out the patient, and all people are not agree to come hospital, and they are taking a regular treatment also. As a relative and person also.
No, I can't understand what is your question. Please, can you? So, what is your query?
Ma'am, we are going to village every day and survey and find out the patient, cancer patient, paralyzed patient, sugar patient. But so many patients are taking irregular medication. We are calling them to come hospital and take treatment, but their relative also not agree to come to hospital. They always telling us we are poor, we have no money, or they're not taking proper treatment also. We are counseling them, and once time come hospital and vital signs, sugar, all this thing we are explaining them, but they didn't come to hospital now. So
that's what. These are problems which are there in rural places.
So in this cases, how we treat them, we are counseling them now. We are counseling.
So see,
them.
That's all. So what you have to do is, it is matter of time. Okay. You have to tell them, and they like only by seeing some. You have here, no, it is our duty, like doing no harm type of thing. We have to explain the risks also. Very young people, if they have diabetes, if they don't take care, simple thing what you can tell is, because we see that in many other states, they go on and on, end up with having renal failure and dialysis. Okay. It is something called as end organ failure. What does diabetes do? It affects all blood vessels. So if they don't take care, if their sugar is always 400 and 500, what will happen? It will affect the kidney. It will affect the heart. See, kidney and heart will get, you have to tell, they can have silent heart attack. They will not have chest pain. They will have heart attack. See, normally we all know when someone has chest pain, and we call it as heart attack. But in diabetes, one biggest problem is, if they don't correct their diabetes, they can have silent myocardial infarction. So these are the things, only if we know, we can tell them. So this is where raising awareness. So you have to tell me, not tell them that I'm not scaring you. I'm trying to protect you. If you do that, so see, as I always say, no, we can only tell. Then it is their duty. So if only thing if we tell, say, okay, they're not having money. So many people are scared, because if I go to private hospital, my whole money will go off. I told, no, in my talk, we have no right. But unfortunately, because people are doing like that, people are scared. So advise them to go to a government hospital. But again, government hospitals should have sufficient resources and things. So everything is not easy to do. So you will have to see what works in your area. Is there a good government hospital where they can go and get treatment? So direct them there. So if they go and see, fortunately, they see a good doctor there, they will develop faith. If you break that cycle once, One
Yes.
person sees someone like that, then that person will go and talk. Then your job will become less. That he or she will go explain and bring the rest. So these are all big, big barriers. This is what the whole world is telling, barriers of healthcare. How and where, how can we do, how can we break it, where, when can I break it? It's not easy, but if you keep doing, and if they have to see the truth for their own eyes,
Yes.
only then. So if we do and show them, like, all what patient said is truth, dear. I have money to eat. I like when I was in Trivandrum, I have seen a patient who said, see, she doesn't have money, like, so she's getting the medicines from a government setup. So
Yes.
she again was a diabetic. So with the money what she has, she's able to eat rice only 3 times. She said, otherwise I have to starve. So when she's taking anti-diabetic medication, she has to eat something, no? So her balance was, will I get rice and eat or starve? Because that much money I have. So here we have also no point in me going and telling, take this wheat diet, that diet, this diet. Where no, her money. So I have to see the situation and speak.
Yes.
With the money what she's having, she's getting some basic medicines from government, some medicine not available, she has to spend money and get. So then she's telling, with this money what I have, this much food only, what food I can get only I will eat. Yes, she has to survive, no? So I have to assess the situation and give advice. Just because I know one advice, I cannot keep on giving that advice.
Yes.
Okay, so we all have to use our common sense, knowledge, see the situation. That's why we say, all what we tell also, you have to use it convenient to your situation. Okay, very good. That's how to manage.
Thank you, ma'am. Thank you, ma'am.
Welcome. Welcome. Anything else anybody wants? Ask. Otherwise, is this last session, Sangeet?
Yes, ma'am. This is the last.
Okay. Then, like, does facilitator want to ask anything else from their perspective also? Is Sheba there today or?
She's on leave, ma'am. She's on leave today.
Okay. So you're happy to get feedback, or what is that you're thinking of?
Yes, ma'am. We can give it 5 minutes.
Yes, that's what. So anybody wants to ask any other doubt in today's session, please go ahead and ask. So all of you know, like, going through the whole palliative care information will be helpful to practice, and also know, so even in your whatever field you are working, all this knowledge and skill will never go waste. So for example, the communication skills what you learn, or the nursing skills that you learn, you can all apply in your day-to-day work. So that is how the whole thing will be helpful for all of you. That's the
Good evening,
important.
ma'am.
Good evening.
Oh, good evening, ma'am. Ma'am,
Go ahead.
मैम जो हमने ये अभी ट्रेनिंग करी है, जो क्लासेस ली हैं, तो इसका कोई सर्टिफिकेट भी मिलेगा हमें क्या, कि हमने ये palliative केयर की हमने ट्रेनिंग ली है? जो भी
Can I answer that, ma'am?
Yes.
Yeah. We are providing a certificate. This is a certified
जी
course. And there are some criteria for passing the certificate, which we have discussed in the first sessions. I'll repeat in that today also. 80% attendance, you have to attend 80% of the total sessions. And that is, out of 18 sessions, you have to attend at least 14 sessions. Then only you will be eligible for the certificate. That is the first criteria. Second, we have 6 assignments. We have so far released 4 only. So there are 2 assignments pending. We will give the time period. You have to pass all the assignments from 1 to 6 for getting the certificate. Is that understood?
Yes, sir. Thank you, sir.
I think if there's no doubt, we can move to the feedback session, ma'am. Is that okay?
Yes, please go ahead.
Thank you, ma'am, for the wonderful session. As today we are going to conclude today's sessions, we would like to hear some feedbacks from you, as we have so far traveled 18 sessions with us, gained many knowledge in various aspects in palliative care. We would like to know how that affects, and we would like to receive some feedback so that if we can improve in some area, that will help with us. Or can anyone please tell what was like this journey?
Any one of you can comment on what is the plus and minus of all these sessions that you had. What is that was good? What is that you would like it to change, or anything to be added? See, these type of feedbacks will be helpful for Pallium to make changes in their future courses also, for the benefit of everyone. So anyone can unmute and speak.
So Shani, do you wish to convey anything?
Yeah. I can speak?
Yeah, sure. Go.
Yeah. Overall, it is a intense content dense course, and the time it is spread over a period of time, and so there is time to study. I think all the people who came as resource, they were experts, and it was a overall great learning experience, at least for me. Palliative care is new to me, and yeah, the point of improvement, I would say some aspects that could be from my what to say side individually, but I was just thinking the proportion of time given for some system, like especially when we are doing the test. I think GI and respiratory were combined. It's a lot of material, meaning the course, content is a. So I thought like that is one observation from my side, and nursing procedures also require a little more time. I don't know what is the technical part of the logistics, how you organize and all that. I felt especially home care aspects, if you can add some things, because not all patients or not all programs have inpatient care. Otherwise, maybe it is within the scope, not within the scope of this program, but I would suggest, these are my suggestions. You don't have to take them as a program feedback, but just thought that would be helpful, because nursing procedures were all clubbed together, and it is being done for, I think, with the keeping in mind that already people are working. Maybe for me that is not suitable. Okay, that is all my suggestions. Otherwise, all the resource people were excellent, and this is all my recommendation is.
Thank you, Sister Shani, for the valuable feedback. Your suggestions are noted. Thank you.
Thank you, Sister Shani. Where from are you? And she's also from Haryana only?
No. I'm not from Haryana. I'm from Karnataka. I work Yeah, right now, I'm not working as a palliative care nurse. I'm new to this field.
Okay, what do you do?
I'm a community health nurse.
Very good. See, thank you for the information. And just few things, as you yourself said, no, logistics and then organize. See, we are trying to condense as much as possible in these courses, and like all your information will be taken and up, and then Sister Sheba is a senior person organizing. She will look into all of that. Just I wanted to add on few things. See, you said more of home care and more about the patient, For that, what I would ideally suggest to all of you, as I always suggest to doctors, nurses, everyone, whenever I go in person, do these courses or do them online, there are few more options. First is you all can visit Pallium and do a hands-on for 5 days or 10 days, which will be very, very useful, because at that point of time, you will get inpatient, and then every day 7 home care teams go out to see patients there. So you can be part of one of the team. So at least 5 days or 10 days of hands-on, either in Pallium, I'll say that is the best. Or you also have a 6 weeks in-house program to know in depth. These are all things which will give information. And then you have to add on the clinical. This is knowledge, then skill, then experience. So all these things, God's grace, we are all able to tell you only with patient care. Okay, more patients you see, more confidence you will get. So that part of it, ideally to do some hands-on, either coming to Pallium is one option, or Pallium will suggest some recognized centers all over India where you can do a 5-day, 10-day, 2 weeks, 3 weeks, 6 weeks, something hands-on also. So together is what will help you. And when you see home care visits and see patients, more information, because that is reality. You'll see patients who really need more of your input. So more such patients. You will see some who are needing routine care. Some may need more intense care. So all those varieties, only when you see, you will be able to comprehend, understand, and realize and work and do it also invariably.
Thank you, ma'am. Any other person who wishes to convey anything? Ma'am, you are muted, ma'am. Ma'am, you are muted, ma'am.
I couldn't unmute for some reason. Now I could. The thing I was about to ask is, all the messages in the chat box you will pick up and convey to Sheba and whatever is needed.
Okay.
Okay, then I'll hand it over to you, Sangeet, then.
Thank you, ma'am, for the wonderful sessions and discussions. Thank you all for being the part of the journey for the 18 sessions. Hope this knowledge will be useful to your career as well. Thank you and best wishes. Thank you.
Good luck, God's grace, blessings, and good wishes to all of you and whatever all of you do. Take care. Thank you, Sangeet, too.